Welcome to week 7 of psychopathology and family systems, and welcome to the only module for this week. We will be studying substance-related and addictive disorders. The substance-related classifications fall into a few different categories. Two are going to be really similar because you've seen them throughout. But when it regards substance-related subclassifications, we have use disorders, then we have intoxication, withdrawal, substance-induced, and then like the other categories of disorders, we have other induced disorders, and then unspecified related disorders. So let's break this down just a little bit to understand use and then substance induced. When we're looking at the use conditions, the pathological pattern of behavior is evidenced through impaired control, social impairment, risky use, and then pharmacological criterion, and we'll go through that. The substance-induced conditions include your intoxication, withdrawal, and then other substance or medication-induced mental disorder. So that would be something like a substance-induced psychotic disorder. Okay, so these are the ways that we will look at this when we consider a use disorder. We're going to be looking at the 4 categories of impaired control, social impairment, risky use, and pharmacological criterion. But when we're thinking about our substance-induced conditions, we will be focusing on intoxication and withdrawal. Okay? So what are our classifications? The drug classifications, there are 10. We have alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, stimulants, tobacco, and then other substances. Like I did with our study of anxiety disorders, I want to go back and focus on the brain. So we have an understanding of what is happening as it regards addiction and substance use. So all substances trigger or activate the pleasure center or the reward centers of the brain, okay? And depending on the type of drug, a different pathway could be triggered, a different neurotransmitter might be impacted. Most are going to trigger dopamine, but different centers of the brain are going to be impacted. And these slides sort of evidence that. At the bottom, you have your normal brain, right? So the first comparison, top to bottom, you're looking at a non-smoker brain as compared to the smoker brain at the top. And then from left to right, we have the alcoholic brain, and we can see how that differs in terms of firing areas from the normal brain. The same with obesity, which is not really in this category, but and then we have cocaine and the difference between cocaine and a normal brain, where cocaine and addiction is not a part of that. So every substance triggers or activates pleasure centers in the brain, which then encourages continued use of the substance, such that in order for an individual to experience pleasure, because it has been artificially triggered and activated, sometimes the brain stops having the capacity to activate and trigger that pleasure on its own without the introduction of the substance, which adds to the addictive nature. So let's delve into the substance use disorders and conditions. The DSM-5 removed terminology like abuse and dependence to define substance-related disorders. Instead, they replaced that with words like use, intoxication, and withdrawal. So we're no longer saying somebody has alcohol abuse or cocaine abuse, suggesting that abuse is less intense than dependence, right? So we've gotten away from that. We no longer use abuse and dependence, and now we instead say something like alcohol use or alcohol intoxication with or without a use disorder. So notice you can have an alcohol use disorder, but you could also have alcohol intoxication with an alcohol use disorder on top of that and indicate whether or not that use disorder is mild, moderate, or severe. You could also have an alcohol withdrawal disorder with or without perceptual disturbance. And then you have other alcohol-induced and unspecified alcohol-related disorders. Now, all of the disorders won't read exactly the same, meaning you can't just say cocaine use, cocaine intoxication with or without, or caffeine or cannabis or whatever the title. But I have given this to you as an example, but each of the classes of drugs may have slightly different categories that either have the perceptual disturbance or don't, and so forth. So I'll try to go over that with you, but this is an example of how we've moved away from use and dependence to use, intoxication, and then withdrawal. The DSM-5 also removed from the diagnostic listing or criteria this notion of legal impact. So one of the questions that we used to ask was the impacts of the substance abuse or dependence. And usually if somebody were abusing alcohol, let's say, meaning they had an instance where they overused, we might say, okay, this person is not using it correctly, but they haven't reached the point of abuse, which often carried with it legal ramifications. Well, we know that people could be dependent, but just not have had a legal consequence. So the DSM-5 again removed that as a criteria for diagnosis and instead replaced it with cravings. Okay, so now we have use, intoxication, withdrawal, and cravings. The essential features that we're looking at for a substance use disorder or substance-related disorder, we're looking to see impacts cognitively, behaviorally, and physiologically that have continued despite there being problems with the use of that substance, and where there has been an attempt to abstain, but a failure in doing so. Okay, so in order to get at these categories of cognitive, behavioral, physiological problems and failure to abstain, there are 11 symptoms total to meet qualification criteria for a substance use disorder. 2 of those 11 symptoms needs to be present. And you can see that's not a huge expectation and threshold, 2 out of 11. The categories are broken down in this way. You have the issues that evidence impaired control, some impact socially, Then you have the risky use, and then your pharmacological parameters. So let's delve a little bit into impaired control. What are we talking about here? When we're looking at a substance use in a disordered way, we should expect to see increased usage of that substance across time. Additionally, we're going to see that attempts to cut back tend to be unsuccessful, and that significant time is spent either thinking about the drug, getting the drug, using the drug, recovering from the substance, right? So people talk about, thinking about tying off their arm and the smell of the rubber as they pull it through their teeth, and maybe even the taste of it as they're trying to squeeze off the arm to get to a vein. So there's that significant time that's spent thinking about and using. And then there's the craving or desire for the substance. All of those suggest an impaired control, the person's inability to control their use of whatever the substance is because of the craving, the increased use, the attempt to stop but not being able to. We also look at how the drug or the substance impacts the person's ability, as always, to carry out usual activities, and one of those is socially. What is the impact on role fulfillment by this? Whatever the role is, it could be wife, it could be parent, it could be an occupational role. The use of the substance has impacted the person's ability to fulfill whatever that role and expectation is. The usage also persists despite evident problems socially, right? Despite this impacting a person's work and performance or the activities that they usually would enjoy in. Perhaps somebody is athletic, but because of the use of substances, their ability to carry out that sort of social expectation becomes impacted negatively by the drug or substance. And then finally, under social impairment, we have activities that the person either completely gives up or significantly retreats or withdraws from because of the substance use. Perhaps it's inability, or perhaps it's an unwillingness, an inability to split the time. So much time is spent that it then interrupts the ability to carry out usual activities. Okay, so that takes care of our social impairment. Then we move over to risky use. And in this category, we are trying to ascertain whether or not the person continues to use or continues to seek out the substance despite the dangerousness of the environment. So one thing that we might think about or have in our mind's eye is a person going into a dark alley to get a drug. Certainly that evidences risky use. Getting drugs off the street in general could also equate as risky use because of the lack of knowing whether or not the substance is clean, pure, those sort of things. But the risky environment doesn't just have to be some dark alley. It could be in the workplace. So what comes to mind for me are nurses who may pilfer from medication stash for clients to divert the medication to themselves. Now, every nurse is supposed to do count with another nurse and then do waste with another nurse, so anything that was not used. But when somebody has a substance use issue, a substance use disorder, those individuals are taking great risk to pilfer medication for their own use, diverting it away from uh, clients and patients in the workplace where they could, of course, be caught. That's also risky, dangerous physical environment, okay? And then under risky use, there's the continued use despite knowing that there are physical and psychological issues that get created. The ravaging of the body that happens, the loss of teeth, the loss of appetite, the impacts to the kidney, the impacts to the body in general. Despite that, there is continued use. Then we go down to pharmacological criteria. And I have an asterisk here around tolerance and withdrawal. And I'll come to this, but on another slide. But let me explain tolerance. Tolerance is, as we would expect, it is an increased dosing to achieve the desired effect. So early in substance use, a lesser amount might be required to create whatever the desired effect is. However, over time and with more use, tolerance builds. Okay, so I'm going to spend a little time here on tolerance, but before that, I'm gonna speak to withdrawal. And in the withdrawal, it is the dissipating of the substance in the person's bloodstream over time. Not every substance has withdrawal, but that is what is meant by the pharmacological criteria. So here we have tolerance, and I want to note, and I do here, that neither tolerance nor withdrawal alone are qualifying for classification as a substance use disorder. For instance, if you just had tolerance and withdrawal, that would be insufficient for the 2 out of the 11. Okay? In other words, other symptomatology in addition to these would be required. If tolerance, and the reason for that is because if tolerance and withdrawal occur during the course of medical care, right, then we really wouldn't give a substance use disorder if, because I'm on this particular medication, I've developed a tolerance, or at the stopping of this medication, there have been side effects indicative of withdrawal. We might see how, depending on the substance, those may be expected responses where you build up the medication over time to get an effect. Right? So we wouldn't want that alone to serve as diagnostic, because that may be the way the medication is meted out. And for anyone taking that medication at those dosages, there will be a withdrawal impact, the body recognizing the absence of that drug. So again, if those are the only 2, we would not necessarily qualify a person as having a substance use disorder. They would need one of those with at least one other, okay? But not just these 2. Certainly, if somebody has withdrawal, then it's going to suggest a more severe clinical course of the substance use, because that means that they've ingested enough of the medication over time that the absence of it in the body is significant and is throwing the person into active withdrawal. Intoxication. What is meant by intoxication? This is a disturbance in the way that the person thinks, perceives, judges, moves, how drowsy or awake they are. And it also impacts interpersonal behavior, okay? Intoxication is the visible representation that a person has imbibed, taken in some sort of a substance. And we would say physiologically, either this intoxication is acute, meaning the person consumed alcohol and we saw an acute or a short-term intoxication, or it's sustained. Some substances, like your opioids, have a sustained intoxication or a prolonged impact in the body beyond the time that the substance is detectable in the system. And therefore, you may see these after impacts on the central nervous system, okay? When we're talking about intoxication, there is no intoxication in the DSM from a tobacco, right? So this is where I said there may be an alcohol use and an alcohol intoxication and an alcohol withdrawal and other specified and unspecified. But each category may not have that. In this instance, I point out that intoxication is not a part of tobacco use. And I've given the specific pages, I believe, in the DSM-5 for the intoxication criteria so that you know that and have that for each respective class. Withdrawal, going back to the pharmacologic parameters. This is, like I mentioned, a declining blood or tissue levels after prolonged or heavy use of a substance. Again, each substance may have different withdrawal symptoms, but the withdrawal effects for alcohol, opioids, sedatives, your hypnotics, and anxiolytics, those can usually easily be measured, meaning we can have people do drug tests or drug screens and determine how much of the substance is still in the system. Withdrawal effects with stimulants and tobacco and cannabis, they're present, but they're a lot less apparent, so not as easily measured, right? So because of that, the DSM says, okay, we're not really going to have withdrawal with tobacco because our ability to test that in the body is really insufficient. Significant withdrawal is also not associated or documented with the use of hallucinogens. There is no withdrawal there. But with withdrawal, if it is a part of the drug class, it's usually accompanied with an urge to re-administer the drug to avoid the withdrawal symptoms. So we know that when people are on heroin and they are withdrawing from heroin, it is an extremely painful withdrawal because the pain is felt even into the bones. And so most who are addicted to heroin have a difficulty getting off of the substance because of the pain associated, and therefore to alleviate the pain and the distress of that will then take more of a substance to ease. Something similar happens with alcohol, where if a person starts to feel delirium tremors, they may start to drink again just to settle the withdrawal effects in the body. Now, the remission specifiers, when we're talking about substance use disorders, we're going to say whether or not the person has early remission, where there is at least 3 months. So a person has to have been had inactive use for at least 3 months, but less than 12 months. Okay, that doesn't mean that the person doesn't have a craving. Remember, that's one of those things that the DSM added in. A person could have a craving but not act on the craving. So when we're talking about the absence of symptoms and criteria, we're not including cravings, but we're talking 3 months to 12 months. Sustained remission is at least 12 months without any of the symptom criteria, again, with the exclusion of cravings. Severity ratings, going back to the 11 symptoms, a mild rating would be 2 to 3 of those, a moderate rating 4 to 5, and then 6 or more would be severe. Okay? So let me just try to give you an overview. I hope this is complete. There may be a thing or two that I missed, but just trying to give it to you in a single lecture. Alcohol does not assess or have perceptual disturbance with intoxication. So you have alcohol intoxication, but no specifier. Caffeine has no use disorder. And it has, so you can have caffeine intoxication, caffeine withdrawal, but there is no caffeine use disorder. And there is no assessment for or specifier of perceptual disturbance with caffeine. Cannabis has perceptual disturbance with intoxication and withdrawal. Okay, and you'll notice alcohol did not have that. So cannabis is one where you're going to specify with perceptual disturbance as it regards to a cannabis intoxication disorder or a cannabis withdrawal disorder. Okay, then with inhalants, there is no withdrawal category. There is inhalant use and inhalant intoxication, but there is no inhalant withdrawal. And with the inhalant intoxication, there is no specifier for perceptual disturbance. When we talk about opioids, the perceptual disturbance is only with intoxication, but not with withdrawal. Okay, I know this sounds like a lot, and you're probably thinking, oh my gosh, how am I going to hold all this together? You don't need to. Go back to your DSM. You can start to, with your questions, ask, do you have any unusual experiences? And maybe that category doesn't require it. You can go back and say, oh, I really didn't need to ask that question. But the reason that I'm highlighting this here is I just want to bring your attention that there is not absolute homogeneity across the classes. Some have intoxication, some have withdrawal, some include perceptual, and I just want to draw your attention to that. With the sedative and the hypnotics, there is no perceptual disturbance with intoxication, but there would be with withdrawal. And then with stimulant intoxication, it's mixed, meaning some will have, some may be with and some may be without perceptual disturbance. And so, again, that's going to be one that you are going to look up directly and specifically. Okay, and so by that, I'm just going to go here through the DSM just so I can relay that to you for clarity. When we're thinking about your stimulants, we are considering things like, sorry, I'm trying to get to the stimulant section. When we're looking at the stimulants, there's cocaine, there's amphetamine, and so you may have stimulant intoxication, right? Or amphetamine or stimulant without perceptual disturbances, and that's under intoxication. Cocaine with or without perceptual disturbance under intoxication and with disturbance. So you indicate in that instance, when it comes to amphetamines or other stimulants or cocaine, you can say with or without, just as is the case with alcohol use. Okay. But again, like you didn't see me, but you could hear me doing, I just go back to my DSM, and before I give a substance related, I'm going to go back and review and say, does this category of drugs even have a withdrawal? Because I wouldn't want to give the diagnosis if it's not in the DSM. Okay. So what are our substance induced disorders? Our substance and medication induced mental disorders are those mental problems that develop in people who didn't have a mental health issue before using the substance. So, an example would be a substance-induced psychotic disorder. What this means is this individual did not have any perceptual psychotic behavior, no perceptual disturbance or psychotic behavior before using this substance, or no depressive disorders before using the disorder. Now, we know that we've studied different classifications of drugs. Here is where, or mental disorders, here is where we start to think, what is the primary issue here? Because people have a major depressive disorder that could be comorbid or coexisting with a substance use disorder, right? In this instance, this is saying this is a person who did not have depression, but as a function of perhaps using a depressive like an alcohol, they have now developed. But our primary focus here is on the substance use. So when we go back to what is the cause, because that gives way to the cure, we are not in this instance treating depression, right? With a substance-induced depressive disorder, we are treating a substance use disorder. And the thought is that when we attend to the substance use issue, it will inevitably attend to the depressive disorder that was created. Okay, so hopefully that is clear. So we have these substance-induced issues, and it needs to be clear that whatever follows the substance induced, whether it's sleep or sexual dysfunction, that is not the problem. The substance is a problem, and it has created this subsequent issue. Our treatment is around the substance issue, and hopefully that will alleviate the created issue. The criteria for a substance or a medication-induced disorder is it presents as a clinically significant mental health disorder, and there is evidence of both. You have to have the development of the disorder or of a disorder within 1 month of taking the medication, substance, and there was intoxication or withdrawal, and the substance is capable of producing whatever the mental disorder was that preceded it. So you wouldn't necessarily say that a substance induced a blah, 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 unless it had the capacity to produce that. So if you're taking hallucinogens, it could create psychosis and create a problem of that on its own. If somebody's smoking marijuana, because of the amount of THC, they might have perceptual disturbances, and now as a function of that substance have now created a psychotic disorder. So there is both a disorder that happens within a time frame of having used this substance where we can pinpoint it's because of this drug, right? And the substance itself is capable of producing blah, blah, blah. Now, we understand that when we go back to the qualifiers, with and without perceptual disturbance, with and without, intoxication, blah, 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 right? So that is where we can help to understand or get a better understanding rather of the second criteria, the capacity to produce the mental disorder. The condition is also not better explained by an independent mental disorder, such that the disorder didn't precede the intoxication or withdrawal or the exposure, right? So again, if we have a major depressive disorder that is present before a substance use, we're going to say this is probably better explained by the mental disorder that preceded it. If depression was in place before the use of the substance, that's probably going to better explain what it is we're seeing, okay? The disorder is not occurring during a course of delirium, okay? And the disorder causes clinically significant distress, blah, blah, blah. We know that line. So when we're talking about delirium and somebody not having a full grasp of who they are, where they are, memories, and those sort of things. If there is the potential for delirium, we're going to pause on a substance or a medication-induced condition. And like with the example with depression, we might say delirium is really our problem, and there's nothing about this medication that may have created a subsequent issue. Okay, because we're going to look at delirium and rule that out. Make sure that delirium is not present. Okay, so that is it for our substance use disorders. What I didn't do is I didn't go through each of the categories, as you could see, because they essentially are similar, but I noted the differences. Use, intoxication, withdrawal, and then your cravings are going to give us our criteria for use, substance use disorders, but again, each category will be slightly distinct. So go and look at it. But 2 of the 11 are still required regardless of the category, okay? And then we understand the difference between a substance induced versus a substance use, okay? The substance itself created the depression, for example. The depression was not present before the use of the substance, or anxiety or psychosis or what have you. So now on to substance or non-substance related disorders. There are a number of things that we say in lay terms and colloquially, oh, this is an addiction. But interestingly, the DSM only includes gambling as a non-substance addictive behavior. That doesn't mean that, there aren't studies in the works for, overspending and those sort of things, but in terms of it being a clinical issue that falls in the DSM, gambling is the only one. And so it's a persistent gambling that causes significant impairment, and you're looking for 4 or more across a 12-month period of time, and I've listed them here. The need to gamble more, repeated efforts to stop but being unsuccessful. Even when distressed, the gambling continues. Even when there is financial loss, the gambling continues. Due to the gambling, friendships, relationships, all of those things, work, are jeopardized. Very similar to the 2 of 11, very similar to those 11, but specific here to gambling. And usually, in order to get out of the debt or hole, more financial help is needed to alleviate um, the financial constraints that have been created. Now, when we're thinking about gambling, we've already talked about bipolar disorders and manic episodes, which are these risky, risk-taking times potentially for individuals who are manic. In this instance, we want to make sure that if we're seeing somebody engaging in this excessive spending, hitting 4 or more of the criterion from the previous slide in a 12-month period of time, we want to make sure that that's not happening during mania. Because if it's happening during mania, that is just a symptom of the mania. Okay? So let's say a person does have a bipolar 1 disorder and they are engaging in this behavior inside of a mania, we would just stick with diagnosing the bipolar 1 disorder. However, they could have a bipolar 1 disorder, and when they were not in a manic phase of the disorder, still have a gambling addiction. So it's just not occurring during a manic episode. Like all of the other categories, there are some specifiers, and we'll specify if the gambling is episodic, persistent, early remission, sustained remission. When we're talking about early remission and sustained remission, it's going to follow the same parameters as the use disorders. Partial, 3 months at minimum, but no more than 12. And then sustained, 12 months. And then when we're looking at criteria, mild would be considered for gambling 4 to 5, moderate 6 to 7, and then severe 8 to 9, meaning all of those criteria were met. Okay? A few things that I want to highlight here, and then we will end, is that when a person has a gambling disorder, about 17% of those individuals will make a suicide attempt. And we can understand that. If you need financial help to dig you out of the financial hole that the gambling has put you in, if relationships, work, all those things have been ravaged, you're trying to stop but you can't, all of the things, we can see how that could lead to suicidality. So with any of the categories, but specifically with the gambling issue, we do want to assess for suicide. Okay? And then when we're looking at the disordered thinking, or when we're looking at this particular disorder, we recognize that there is an element of disordered thinking that accompanies it that we're also going to be assessing for. That overconfidence, competitiveness, the reliance on superstitions, and even the person believing that they have power over chance. We're assessing for all of those things to get into the mindset of the person, because not only are we trying to help with the gambling overall, we're trying to, in our treatment, target the cognitive and distorted errors that are happening as well. Okay, So that does it for week 7. I hope you have a better, clearer understanding of substance related and addictive disorders. The only non-substance related disorder is gambling, and the other drug categories are probably familiar. Thank you.